Good afternoon, and thank you for joining. It's a pleasure to be able to speak with you today and to present this program, Phase 2, Making Telehealth Work for Your Practice. My name is Dr. Barry Bittman, and I'm working today with Mitzi Young, RCMA and CMA physician advocate to deliver this program. I'd like to begin by thanking Dolores Green for enabling this to happen with the Riverside County Medical Association. I'd also like to thank the San Bernardino Medical Society for partnering with us, and certainly for tremendous support from the Inland Empire Health Plan, IEHP. I want you to know that our presentation will be available on our website, our CMA Docs. You should check into it, not only for this presentation, but for additional information that's available and quite comprehensive on COVID-19 and other challenges that we're facing. On behalf of our team, I'd like to thank all of the PCPs and specialists who are on the line today. And I want you to know that if you have any questions or further interest, we'll be able to work with you closely, and we'll present that information at the end of the presentation. Given the number of individuals that we have online, we're going to resort to our chat feature for questions, so please type them as you see fit. So let's begin. The purpose of our presentation today is twofold. Essentially, what we're attempting to do is to provide recommendations for the ongoing use of telehealth in the construct of taking care of our patients now during this COVID crisis. We'd also like to focus your attention on the continued use of telehealth, on making this work as part of our routine practice. I think that most of you who are participating on this call as physicians clearly recognize that there are a host of advantages and efficiencies that come with telehealth. While it's not for everyone, it certainly is beneficial for a number of patients. It provides a convenient opportunity to perform high-level care. I also want to mention that this is a great opportunity for utilizing telehealth for annual wellness visits. Many practitioners are not aware of it. However, this is a great way to perform those annual wellness visits during this period. As we move forward, I'd like to share a couple of quotes with you. This first one actually came out on April 30th, and it was by Judd Hollander and Brendan Garr. And the title was virtually perfect: Telemedicine for COVID-19. I really don't read my slides, but I'd like to read this quote. A central strategy for healthcare surge control is forward triage, the sorting of patients before they arrive in the emergency room. Direct-to-consumer or on-demand telemedicine, a 21st century approach to forward triage that allows patients to be efficiently screened, is both patient-centered and conducive to self-quarantine, and it protects patients, clinicians, and the community from exposure. It can allow physicians and patients to communicate 24/7 using smartphones or web-enabled computers. Respiratory symptoms, which may be early signs of COVID-19, are among the conditions most commonly evaluated with this approach. Healthcare providers can easily obtain detailed travel and exposure histories. Automated screening algorithms can be built into the intake process, and local epidemiological information can be used to standardize screening and practice patterns across providers. And that was, by the way, in the New England Journal of Medicine, April 30th. I'd like to show you, however, how our thinking clearly changes and changes rapidly. This is what happened in 2 months, and it was a surprise. This is the next article I'm quoting, which appeared in Stat News. It's entitled, "This is supposed to be telemedicine's time to shine. Why are doctors abandoning it?" And this was written by Ativ Mehrotra and David Linetsky and Hilary Hatch. I'm going to read this one as well. From almost no telemedicine visits before the pandemic struck the US, by early April, almost 14% of the usual weekly number of pre-pandemic visits were conducted via telemedicine. The assumption among many was that after witnessing the benefits of telemedicine, physicians and patients would embrace it and growth would continue. That hasn't happened. In fact, the use of telemedicine is now steadily declining. And during the week of June 14th was used for only 8% of the usual pre-pandemic number of visits. In the midst of a lockdown and stay-at-home disorders, physicians did what they could and switched to telemedicine as their only option. Because of technology problems with video visits, many reverted to phone calls. But as we're getting into a new normal and communities are reopening, making in-person visits an option, many physicians are deciding the investment in telemedicine is not worth it and are abandoning it. Now that's a change that's occurred over just a 2-month period. It may be somewhat different now based upon the fact that the numbers are escalating precipitously and the use of telemedicine might be increasing. However, when you look at the screen, you can realize what the actual use among healthcare organizations actually has been in accordance with the dates through June 14th. As we proceed forward, it becomes apparent that this region has been experiencing extraordinarily interesting and what I was saying about this slide is that it's really interesting to note that the telemedicine use overall among healthcare providers waned, especially toward the middle of June. Now, this may be different at this time clearly, based upon the fact that we're facing additional challenges, which I mentioned on the subsequent page. And just to repeat, on the left, you can see the relative trajectory of patients, and on the right, you can see the percentage of positive PCR tests. Bottom line here is that what we're starting to experience is worsening of the COVID crisis, as you all know, and I would guess that the utilization of telehealth is increasing. However, I'm not sure. The real question is, why did it decline? And why would it decline in a period where extra care and vigilance is more important now than ever before? What I'm going to do is basically give you 5 reasons to continue using telehealth and reserving your office for those who must be seen in person, especially during these challenging times. Reasons 1, 2, 3 are pretty straightforward. They're actually combined, and they provide the rationale for the use of telehealth. The first is the widespread CMS and health plan reimbursement accommodations, which, as you know, are now on par with face-to-face visits. The second is focused on relaxed HIPAA regulations that allow us to use FaceTime and similar apps. And the third is newly discovered efficiencies that enable your practice to use telehealth now. Now, some of you may be wondering about that, but I have had the opportunity to speak with and continue to speak with providers all around the country. And they tell me that telehealth is terrific because of the fact that it essentially eliminates no-shows. And rather than wasting that time, they're able to put patients into telehealth slots easily. And I guess the cancellation rate or no-show rate is practically 0. So if you're looking at your overall practice, that efficiency is certainly worth considering. Reason number 4, asymptomatic transmission is high. And this comes through the end of June via the CDC. And this data is extremely important. What they're essentially saying is that 40% of infections are asymptomatic, and that asymptomatic patients may not be as infective as symptomatic ones, but it's probably at the 75th percentile level. And we have to be concerned with these numbers because of the fact that what we're dealing with now is the potential to overwhelm our healthcare system. Another great reason to get back into telehealth presently. And reason number 5 is something that is really concerning at this point. And this is the data that unfortunately shows that as you move through the first 4 days of exposure prior to symptom onset, on day 1, PCR has 100% false positives. And by day 4, 68% false positives. So let me state it another way. If you were to have a patient exposed today and you tested them tomorrow, chances are that you wouldn't pick it up. Even 4 days after exposure, there's a 68% false negative rate. And this is on PCR. We're not talking about antibody tests. And I really want to caution you in this regard, not only for patients in your practice, but patients who are also scheduled for elective procedures or surgeries. This is concerning because a test within 4 or 5 days is not adequate based upon this data. So I've essentially given you my 5 reasons for why you should continue now. And my co-presenter, Mitzi, is going to take it from here, and she's going to provide some additional perspective.
Thank you so much, Dr. Bittman. Good afternoon, everybody. My name is Mitzi Young. I'm the physician advocate for the Riverside County Medical Association and the California Medical Association. I want to start off today by just thanking you. From the bottom of our hearts, we really thank all the work that you're doing every day in this pandemic. I also want to thank you for your membership. Your support in the Riverside County Medical Association allows us to do the work on your behalf at a very high level. Our advocacy is really important to us, and that we make sure that we protect the profession of medicine. So once again, thank you so much for your support at the Riverside County Medical Association. So let's go through some preliminary suggestions on telemedicine and how it works in your practice. So we know that telemedicine has emerged as an effective approach for assisting with the management of chronic conditions among other vulnerable patient groups who experience difficulty accessing routine health care, such as homebound adults, frail elderly, and people with physical disabilities. So really you need to make sure that you're looking at your strategies inside your office, putting really good policies together on how telehealth is going to work for you. And if that is something that you're struggling with, please don't struggle. Just give us a call. We're right here to help you with all the free benefits that are available to you and your staff. So really your practices should consider staffing adjustments. So which may include scheduling staff and physicians on rotating teams, or via telecommuting for certain positions if it's at all possible in your practice. Again, for more information on employment issues, you need to see the RCMA COVID-19 toolkit for physician employers. And if you need that, you can certainly email me directly. I'd be more than glad to help you with that. Again, the other thing that you need to make sure inside your practice, this is kind of administrative, is that you have your warning signs. We've got those signs available for download at rcmadocs.org/coronavirus. So if you need those, make sure that you get them. And again, if you want me to email them to you, I'd be more than glad to do that for you. The other thing that we need to consider is the barriers to patient use with telehealth. So the more platforms a telehealth solution operates on, mobile, desktop, browser, etc., the more options your patients will have. So it's a really good opportunity for you to take a look and work with your platforms if that's what you're doing right now. You have a platform in place, in even your EHR has a platform or your practice management system. Make sure that you have these options. Additionally, a solution that offers a simple link via email or text might be easier for some patients than one requiring an app download. So sometimes there's some that have app downloads and patients struggle with those. And so you just want to make sure that you know all of the options for your systems. Next slide. So scheduling and prioritizing telehealth services. So there's a few ways of doing this. So I really think that efficient scheduling and reduction of no-shows, those are kind of the things that we really need to look at as essential factors. So there's a couple of suggestions that I'm going to make. One of the first suggestions is telemedicine time block. So telemedicine time blocks reduce the double scheduling while keeping the schedule organized. It provides for providers and managers and staff to determine a period that is set aside for the telemedicine scheduling only. So most common that I'm hearing about right now is increments is about 2 hours. So you would just block out some of your schedule just for your telemedicines visits, and you wouldn't kind of, put those in your regular schedule, although you could do that, and I'll get to that in a moment. Telemedicine days. So days dedicated to telemedicine may meet the provider's availability. In the case that they offer telemedicine service throughout the day, one-on-one or more days per week. So I would probably start, depending on what kind of telemedicine volume you're doing right now in your practice, start off with 1 day of telemedicine or a half a day, and then add as needed. And then the open schedule are those that are able to review and approve appointments throughout the day, or who want to offer urgent care appointments with some flexibility. The open schedule option is available. So you have to just kind of determine within your practice what suits you best. Video visits are proven to improve the efficiency at which practice operates and reduces time spent with patients without sacrificing quality of care. I did read a couple of studies. The average time a physician spends with a patient in the United States is 17.4 minutes on average. Physicians who use telemedicine are seeing a reduction in visit times by about 20%, with the average visit time in one study being as low as 12 minutes. So timing is everything when it comes to telemedicine, right? So we know that, patient wait times are really kind of a really big complaint just industry-wide. We know that that is an issue. Most practices know that that's an issue, and they come up against that sometimes. So with telemedicine, I think that we're able to really focus more on that visit than you would kind of maybe traveling down a different lane when they're face-to-face. So it does show in some of the studies that I've read that it is a little bit easier to shorten those times due to the fact that you're able to focus directly on the issue or the problem of the visit. Next slide. So prioritization. So CMS recognizes that, conservation of critical healthcare resources is essential. Obviously in these times right now with our cases going up and people being limited in their amount of time they can spend, limiting exposure of patients and staff to the virus, that causes COVID-19. CMS also recognizes the importance of reducing burdens on the existing healthcare system and maintaining services while keeping patients and providers safe. So the recommendation to postpone non-essential surgeries and other procedures to limit those medical services that could be deferred, such as non-emergent, elective treatment, and preventive medical services for patients of all ages. CMS has done a tiered framework. It is recommended to prioritize these services and care to those who require engagement or urgent attention to save a life, manage severe disease, or avoid further harms from an underlying condition. So I think that this is a really good slide that perhaps you want to make copies of and go over with your providers and staff within the office. Again, if you need some help with this or clarity, be more than glad to do that for you. Let's go to our next slide. So our workflows are really important. So if we look at kind of what we were doing previously on scheduled office visits, and then what you would do is you would take these workflows and the CMS tier classification, discuss it with your providers, right? Because we've got the 1, 2, and 3. And then we're going to transfer those over to new office visits and how you're going to do it and how you're going to classify what that visit is, tier 1, 2, or 3. Next slide. So workflow 2 is really going to be about your office staff and the provider workflow. So this again, I think that these 3 slides that I've just gone through, really important slides for you to maybe make a copy of, make sure everybody in the office has got them. Let's sit down and have a really nice meeting with the staff and providers together and figure out exactly what's working, what's not working in workflows within your office. And certainly if you need some management of that and some help, we are absolutely here to help you. Next slide. So the annual wellness visit, Dr. Bittman talked a little bit about that. This is really, really important that folks know that the annual wellness visit can be provided to all Medicare Part B patients. Use the service to identify patients who would benefit from a discussion regarding their self-management goals. Choose patients the staff has identified as higher risk. Staff are concerned that the patient is unable or unstable or may be more likely to need additional services or have recently been to the ER. Use this service to risk stratify your patient population. Use the service to document diagnosis and conditions to accurately reflect patient severity of illness, your HCCs, coding, and risk of high-cost care. So annual wellness visits are something you absolutely should be doing. It will generate more income in your practice, which right now we all need to see that happening. And so if you need help in kind of understanding that a little bit more, we've got everything that you need. So just give us a call and we'd be more than glad to get that to you. Remember that we have resources at the ready. So I don't want anybody struggling to look for resources. You know, I'm going to give you a half an hour. You have a half an hour to look for your own resources. After that, you need to pick up the phone or you need to email us and we can get that stuff for you real quickly. Next slide. So again, you know, I'm just going to reiterate again, it's an unprecedented opportunity. Annual wellness visits are something that, you know, we certainly need to encourage you to do. We've kind of given you a little bit of a guide in this slide. Dr. Bittman did this slide, so thank you, Dr. Bittman. If you have anything else you want to talk about in this slide, Dr. Bittman, I'd be more than glad to give that over to you. But I really believe that if you're struggling with them and you don't understand how they work and how they can be so effective in your patient population, and doing them via telehealth, we're more than glad to help you with that. And with that, I'm going to send it back over to Dr. Bittman.
Thank you, Mitzi. And you know, the one thing I want to emphasize when it comes to annual wellness visits is you might be saying to yourself, I really can't do it because I can't do the physical checks or evaluations of blood pressure, weight, and so on the patients. And I want you to know that it's acceptable to, one, either take the information from the patient if they have the equipment to do so, or two, to basically state that you were unable to get those measures. You will still get paid for the annual wellness visit, and at a later time when you can see the patient, you can document in accordance with the information that you have. The one thing that is of additional concern to me is that many practices have furloughed employees, meaning that practices typically are not working up to par because, especially during a surge in cases, people don't want to go out and actually present to a doctor's office. This is a great time to bring those people back on board, meaning your staff. Set up an organized telehealth strategy and basically go through your patients, especially your at-risk ones. And this just doesn't apply to Medicare. This applies to IEHP, to other insurers as well, and get those patients in. This is not only an opportunity to do an annual wellness visit, it's also a phenomenal opportunity to do proper RAF coding. And if you're in a capitated system, that can make all the difference. The additional benefits, as I was mentioning, are clearly beyond RAF coding. It extends to patient engagement and adherence, especially for those who you are worried about. It can foster earlier diagnoses. What I mean by that is physicians don't have three-point radar. They really don't know what's going on behind their backs. And the people who tend to schedule are often people who have scheduled 4 to 6 months in advance for routine care. The people who are in trouble tend not to schedule until they're in big trouble. And at that time, it typically means an ED visit or a hospitalization. In fact, many of you might not even see those patients until after they're discharged. So this is a great way to create a list of your at-risk patients, go through your EMR, find out who those patients are, and ask your staff in their spare time to schedule those individuals, get them in for annual wellness visits, and let's work together to prevent some catastrophes by establishing earlier diagnoses. This also helps us identify patients who need care coordination strategies. It certainly improves quality measure reporting and performance, which often adds incentive payments depending on the payer. And it certainly improves patient outcomes and satisfaction scores. The annual wellness visit components are pretty straightforward. If you're not routinely doing these, this is a great time to start. It's a simple health risk assessment, which you can actually send to the patient, or you can have one of your staff members do it online. It's current medical and family history, and that's typically documented in the context of whether or not there's a change. You're probably wondering about how to do medication reconciliation, but the bottom line is you can ask the person to hold the pill bottle in front of the camera, and that's pretty straightforward. You need to know the patient's current providers and suppliers. And of course, in the context of our opioid crisis, we have to know what they're using and whether or not there are other pain therapies involved. The height, weight, BMI calculation, vital signs I discussed previously. You want to do a quick assessment, a cognitive assessment, and also a quick depression screening. You don't have to do these. Again, a member of your staff can do it. You can do a very simple gait test where you can ask the person if they're stable to have another person in the room with them, and they can get up from their seat and they can walk to a specific area and back to the camera, and you can make your assessment that way. Screening for ethanol misuse, tobacco use, or substance use is obvious, and that's part of what we do, whether this is an annual wellness visit or not. The only part that a high-level practitioner or yourself really has to personally do is that personalized prevention plan, which basically lays out what your strategy is, your recommended strategy for the patient for the year. And finally, and this is not in any way, shape, or form a mandated component, but it's something that we recommend, and that's advanced care planning, meaning you can actually do a pulsed through a telehealth visit. You're probably saying, well, how do I get the signature? All you have to do is document what you're doing. You can send the patient the form, they can sign it and send it back to you. It's really important as we move through these very challenging times that we realize that everything else cannot be left at the wayside. And people are still facing the same challenges. In fact, sometimes to a greater extent than they were before COVID. In fact, my estimation personally is that for every COVID death, there's probably a death attributed to a person with an exacerbating chronic condition who decided that they weren't going to come in and get help because they wanted to prevent the exposure. So this is a time where you can really get your practice aligned and figure out where you need to be and how to proceed. This was the question that I addressed previously, whether or not beneficiary provided vital signs are sufficient for the annual wellness visit, and you can see here that they actually do. The idea is not to abandon the annual wellness visit because of the fact that you don't have the patient in front of you to weigh or measure their blood pressure or pulse. And finally, this is an example of a telehealth annual wellness visit workflow. It basically takes you from your patient to figuring out who your at-risk individuals are, refining your list, establishing some telephonic outreach to those patients, deciding whether or not they're willing to schedule an annual wellness visit. You can email or direct the patient to a portal, depending on your system, for the health risk assessment. You can have ancillary providers help you with this and do most of it. There is a role, as I mentioned, for a high-level person. And finally, you have to develop a personalized prevention plan and hopefully an advanced care plan for each patient. I recommend also that you set up patient surveys and follow-ups afterward to see, as Mitzi so appropriately mentioned, whether or not this is working and whether this is satisfactory for your patients. I want to emphasize something that's really important here. One size does not fit all. There can be certain patients who are going to do very well with telehealth and others that simply won't. There are going to be patients that can handle advanced telehealth workflows dependent on the integration of the system with your EHR, where the scheduling, the follow-up, just about everything is handled automatically. And there are going to be other patients who are willing to do patient visits or annual wellness visits, but they're going to need more hand-holding. They have no problem using their phone or their iPad in order to do it, but they're not going to handle all the automation that's built into your system, perhaps. What we're seeing is that a number of practices have actually gone ahead during this period and purchased more advanced systems that fully integrate with their EMRs. And others are still using basic systems like FaceTime, which are independent from your EMR, but allow you to document in accordance with standard policies. The important thing, again, is one size does not fit all. Your staff knows your patients well, and they can work with you to select the appropriate patients that can be addressed through telehealth. Bottom line is that as we move forward and we move past this challenge, you're going to find more and more opportunities to provide routine care, not the type of care at level 2 or level 3, but routine care that can be handled without having that patient have to come to your office. With that, I'm going to turn this over to Mitzi.
Thank you very much. Okay, so we're about wrapping this up, and I see we've got some good questions coming in, so keep those coming, guys. So where we want to talk about the medical practice employer guidance. So we are getting, a few calls, I would say, they slow down and then they start to pick back up on offices that are having employees that are testing positive for COVID-19. So we have put a little toolkit together that kind of gives you everything that you need to do, step-by-step directions. This is all current information from the CDC, the California Department of Public Health, Riverside County Public Health Department. So this kind of gives you everything that you need. If you need this little toolkit, you can find it on our website at rcmadocs.org/coronavirus. Again, if you can't find it or it takes you too long, please make sure that you give me a call. I'll shoot this out to you. I think it's really important that everybody have this in their policies so that everybody understands exactly what you need to do on the practice level and also on the patient and staffing. Next slide. So if any of you are not yet signed up to be part of the Manifest MedX, which is the health information exchange for Southern California, I would highly suggest that you do this. This is a tool that I believe can be just a game changer in the practice. Again, we've talked a lot about this at RCMA, and we've done some webinars on these subjects. And so again, I just want to make sure that you guys understand what the benefits are, certainly of adding Manifest and getting signed up with them. Most importantly, again, money is a really big deal right now for businesses. And any of you that are running these businesses understand that. So there are some incentives available with signing up with Manifest MedX. And if you have these 5 EHRs, they're going to give you some incentives based on a 3+ provider practice. So again, it's money in your pocket. So make sure that you're getting yourself signed up, your system signed up on Manifest MedX so that you can participate, get this information on your patients when they're entering the hospital and exiting the hospital, and COVID testings. So the labs will let you know right away. These are things that are going to be really important moving forward for you all. And so it helps to keep those patients a whole lot healthier. Reimbursements, obviously play a part in this for you. So this is something that I really encourage all practices to get signed up on. Next slide. So of course I want to make
sure.
Yeah.
I'm going to go back.
Oh, sure.
Because on this slide over here, I want to emphasize the fact that while we recommend you contact your EMR EHR vendor for a telehealth option if you're looking for one, if you're looking outside that venue, we have telehealth vendor options on RCMA docs as well that can greatly help you identify affordable programs that can be used in your practice. Some of them are integrated, some of them are not, but the choices are there. So we've sort of done that shopping ahead of you, and we provide that information. And
Fantastic.
With that, I'm going to turn back to the final slide.
Yeah, thank you very much. So again, we have our resources. We've got everything kind of all work smarter, not harder, guys. Like we've got it all done for you. We've given you a lot of information today. Certainly we've given you, the easy way to get this stuff done, and that's reaching out to us and letting us help you. We provide free one-on-one assistance. Certainly if you need something in the practice or you want to do a Zoom meeting or a conference call with me to kind of help with policy, procedures, workflows, things like that, by all means, just reach out. I'd be more than glad to do it for you. That's what I'm here to do. That's what I get paid to do, and it's what I love to do. Again, I want to thank you so much for all the hard work that you're putting in to the communities and the hospitals and our patients. We really, really appreciate it. We mostly appreciate your support in the Riverside County Medical Association and all that we're able to do on the advocacy level for you. So please know that your membership dollars are working so very hard for your profession. Thank you for joining us today.
And I'd like to thank you as well, and thank my co-presenter, Mitzi. She provides a wealth of information, insights, and support for practices. So please don't hesitate to contact.
Thank you, Dr. Bittman and Mitzi, for presenting this webinar and the knowledge that you have shared with everybody. And thank you to all of our participants. And again, we can't encourage you enough to contact any of our staff on this slide that you're seeing, and we would be happy to help you in any way possible. And if we don't have the answer, we will find the answer for you. So again, thank you very much and enjoy the rest of your day.